talk about diverticulosis and diverticulitis. So in diverticulosis, it's caused by repeated straining during defecation, and this can increase your wall tension. And as you increase the wall tension, you can actually get a weakness in one of the layers of your GI tract, your muscular layer. And specifically, it's where the vasa recta penetrate the muscle layer. I'll talk about that in a little bit. And what can happen is that with this weakened layer, the first two layers of your GI tract closest to your lumen can actually start pushing through that layer and create a blind pouch. Let's talk about what that looks like. We have repeating straining during defecation, causing increased wall tension. So as you're straining, as you're going to the bathroom, you're actually putting a lot of pressure on your walls of your colon. This tension can create a weakness where the vasa recta penetrates the muscle layer. So here's some weaknesses here where the vasa recta penetrate. And what can happen is that the mucosa and submucosa can push through those layers, and now you have diverticulosis. I want to show you specifically where that muscular layer is getting penetrated so you have an idea. Vasa recta are capillaries that supply our bowel wall. So here's some capillaries, and they arise from the mesentery, and they have to supply the blood from out to in. So they're kind of going in this direction. The problem is that where they actually penetrate our muscular layer, it's a little bit weaker than most of our other areas. So right here can get a little bit weakened because you have these capillaries that are coming in right through this region. And when that happens, this wall tension that we just talked about from straining so much can actually push these two layers right here all the way through and break through that muscular layer that we just had. And because this happens, because there's actually a breakage of one of our layers, this is referred to as a false diverticulum. I've shown you these GI tract layers so many times, you're probably sick of them, but we have our lumen, mucosa, submucosa, muscular layer, and serosa. And in a true diverticulum, you have the outpouching, or the diverticula involves every layer, whereas in a false diverticulum, you lose your muscular layer. So here's a true diverticulum where all four layers you can see outpouching here. That can happen in Meckel's or a true appendix. And a false diverticulum here, you can see that we've broken through our muscular layer, and now we only have 3 layers here in our diverticulum. And that can happen, and we already talked about Zanker's diverticulum earlier, but in this case, it can happen in diverticulosis as well. Risk factors for this: advanced age is a risk factor. Low fiber or a high fat diet would also cause this, or could cause this. Obesity is a risk factor. Constipation is probably the most obvious risk factor given what we talked about earlier. So now let's move on to how this presents and what can be the problems with it. Most of the time, diverticulosis is asymptomatic. One thing you should keep in mind is that it is a common cause of painless GI bleeding, especially in the elderly. It's actually the most common cause of painless rectal bleeding in older adults. Another thing you should remember is it's more commonly resulting in left lower quadrant pain when you do have pain. And that's because most of the disease is located in the sigmoid colon or the left colon as well. So it makes sense that most of the pain, if you do have it, would be localized to that region. And here you go, you can see if you're straining, that back pressure is going to come up here, and it's going to cause more diverticulosis in this region relative to others. A couple complications we should think about is diverticulitis. Well, actually, this is the main one. I'm going to have a whole slide on it in just a minute. For treatment, how do you treat diverticulosis? They like to test this, and they'll give you a bunch of answers, but the first line is always dietary modifications. Encourage a high fiber diet so that they're less constipated and that you have less wall tension and less diverticuli. You could also consider a few other, you can do reduced straining as well as like activity modifications. I don't know why they separate these. I guarantee you though, like they won't give you both of these as options on a test. They'll just give you high fiber diet. So just go with that one. I don't think they actually have tested the reduced straining as often. But let's talk about diverticulosis. diverticulitis in the meantime. As the name suggests, it's an inflammation of your diverticula, and it's usually caused by obstruction by fecal material, similar to appendicitis. So remember, diverticulosis is just where you have a blind pouch, but no infection yet. In diverticulitis, you can have, let's say you have fecal obstruction here, all this area can start to get inflamed and cause some problems. This does present with left lower quadrant pain because it's an inflammation. You can also have a fever for the same reason. Leukocytosis makes sense. You diagnose this you can diagnose this by CT scan. You don't need to really know what a CT scan for diverticulitis looks like, and you treat it with antibiotics. And I don't think you need to know specific diverticulitis antibiotics necessarily. It's good to have a grasp of some GI tract antibiotics, so I wanted to give that here. You need to make sure that you're covering your GI tract flora, which are normally gram negatives like E. coli and different types of anaerobes like B. fragilis. So here's a few example regimens that I want you to consider. You could always consider something like Augmentin. And then what they like to test more though is they like to give you metronidazole, which covers your anaerobes generally, and you can take it with the fluoroquinolone, which will cover the gram negatives, an aminoglycoside, a second or third generation cephalosporin like ceftriaxone. So they like to give you some sample regimens. They'll keep it simple, and just remember that the metronidazole is your anaerobe coverage, and then these would be your gram negatives. Oh, and then Bactrim's also, I saw this Bactrim's sometimes used in the spot. I'd honestly say on tests, you're probably going to get Cipro and metronidazole or ceftriaxone and metronidazole. Probably the most common ones. I assume they're testing nowadays. Aztreonam is also an option. I didn't realize I had another option here. It's funny. Don't pick Aztreonam. I mean, I guess you could, but I haven't seen that be correct too many times. Okay, so complications of diverticulitis, you can get perforation, you can get bowel obstruction, you can get an abscess, or you can get a fistula. So let's just talk quickly about what those look like. For a perforation, that should make sense. If you have all this repeated inflammation, that could ultimately blow up and you have perforated bowel. For an obstruction, that could also make sense. If you have continued inflammation or you can get blockage in that area and get an obstruction. For an abscess, again, because it's a walled off area right now, it's hard for any drainage to happen, and it can fill up with an abscess. Fistulas can happen just like they did in Crohn's because this can contact a different organ like the bladder and start to form inflammation in both regions, ultimately leading to a fistula. And that's it for diverticulosis and diverticulitis. Let's move on to another cause of GI bleeding, angiodysplasia and HHT. So angiodysplasia is just a dilation of colonic capillary beds, and this can cause GI bleeding. So if here's our 4 layers of our GI tract. We have our lumen, mucosa, submucosa, muscular layer, and serosa. In this format, what happens is that we have capillaries and veins, and they're going to extend all the way to the mucosa, and the vein will come all the way back down. In angiodysplasia, and then you have connections between the two. What I want you to realize is that in angiodysplasia, you have dilation of all these capillary beds that are supposed to work in unison. So you have this really bad dilation, and it can cause, it basically causes too much pressure within this low pressure system, and that can result in bleeding or hematochezia. Remember that diverticulosis is the most common cause of GI bleeding in the elderly, but angiodysplasia is number 2, so keep that in mind, and colon cancer is number 3. For diagnosing this, you can find tortuous, which is kind of like windy vessels seen on angiography or colonoscopy. Here's a picture of one here on a colonoscopy. There's some associations that are rarely tested, but good to know. Angiodysplasia is associated with ESRD, von Willebrand disease, and they do test this more for step 2, but they like to test somebody who has angiodysplasia and aortic stenosis, and you just have to know that's HHT syndrome or HHT syndrome. That's it for angiodysplasia. We'll talk about HHT, which I always think about in my head as genetic angiodysplasia. So it's an autosomal dominant vascular disorder, and it's typified by what the name suggests, telangiectasias throughout the GI tract. I showed you this picture in the oral cavity lecture, and here you can see lip telangiectasias and tongue telangiectasias. And this will present as painless bleeding. So it could be nosebleeds, any GI bleeds, and that's how it presents. And they'll usually give you a family member who's had it as well to give you an idea that, okay, this might be a genetic condition. And it can lead to arterial venous malformations in the lungs and CNS. And what happens there is that you can actually have these connections, these that shouldn't really be forming directly from the arterial or artery to the vein, and that can cause a whole host of problems as well. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.